therapy, which is part of the European Week Against Cancer that starts today and will continue until the 31st of May. This webinar is the latest installment in a series focusing on different messages of the European Code Against Cancer, with today's webinar focusing on message 10. My name is Francesca and I'm the Community and Communications Assistant at ECL, and I will be a host and moderator this afternoon. We can go to the next slide. I'm delighted to introduce to you today first Dr. Jeva Margarin, the Executive Director of the Institute of Cancer and Crisis and part of our Youth Ambassadors program. Also Dr. Isabelle Romieu, Senior Visiting Scientist and former head of the section of Nutrition and Metabolism at the International Agency for Research on Cancer. And finally, Dr. Mangesh Thorat, a specialist breast and oncoplastic surgeon by training, currently working at the Center for Cancer Prevention at the Wolfson Institute of Preventive Medicine. My colleague Gina Papi, the Communications Officer, and David Ritchie, our Cancer Prevention Manager, are also here with me. And I hope you're all prepared and excited to learn more about the European Code Against Cancer, tool very dear to us and cancer leagues across Europe, and about the benefits of breastfeeding and why it is a cancer protective factor and why hormone replacement therapy is a cancer risk factor. In terms of the agenda, I'll go over a few housekeeping items. Dr. Margarin will give a brief overview of the Code Against Cancer and our Youth Ambassadors program. Then Dr. Thorat will present for about 15 minutes before taking some questions. And finally, Dr. Romeo will also present for 15 minutes and take some questions before wrapping up with a short quiz to test your memories and your knowledge, and then some concluding remarks from my colleague, David. Next slide, please. For a few housekeeping items, to ask questions to our keynote speakers, please type into the Q&A function. We'll strive to answer to as many as we can within the time limits, but we won't be able to answer all of them live. This is also a view-only webinar, so make use of the raise hand function today. After the webinar is over, you will be directed to a short feedback survey. We value your feedback dearly, so please take a minute to answer these 4 questions really quickly. This webinar is also being recorded, so when you receive a thank you email, you will also receive the recording and the presentation slides in the coming weeks. So without further ado, I hand over to Dr. Margarin, who is presenting the Youth Ambassadors program today and has been an ambassador for Armenia since 2019.
Thanks a lot, Francesca. Jeva Margarin, as said before, and I'm very happy to talk about the European Code Against Cancer and about my experience as a youth ambassador. So first of all, what is European Code Against Cancer? It is an initiative of the European Commission and is based on the International Agency of Research on Cancer, which has the European Code Against Cancer has 12 recommendations, which are based on the latest evidence and are aimed to decrease the risk of cancer development and cancer death. So those 12 recommendations are: first is do not smoke. Second is to have smoke-free house. Third is to take actions to maintain healthy body weight. Fourth is to be physically active. Fifth is to have healthy diet. Sixth is to cut the alcohol or to decrease the amount you use. In terms of cancer, it's better to not use alcohol at all, because even small amount of alcohol is increasing, it has been associated with the increased risk of cancer. The seventh code is to avoid sun exposure. The eighth one is to avoid exposure to carcinogens at the workplace. The ninth is to check whether your house or the place you live is exposed at naturally high level of radon. The 10th is to breastfeed if you can, which is for women, of course, and to use hormone replacement therapy cautiously or to avoid using it all, because they're also associated with the risk of cancer. We will actually discuss this code today and we'll learn more about it in details. So 11th is to get vaccines for hepatitis B for newborns and for human papillomavirus. And 12th is to get screened, to participate in cancer screenings. For women, it's cervical cancer, breast cancer screening, and for men and women is the bowel cancer screenings. So I think we can move to the next slide. Yeah, today, as I said before, we will talk about the message 10, which has two components. First is breastfeeding, which reduces the mother's risk of cancer. So if you can breastfeed your baby. And second is hormone replacement therapy increases the risk of certain cancers. Limit use of hormone replacement therapy. And of course, do not use hormone replacement therapy without indication, without prescription. So what is European Cancer League's Youth Ambassador Program, and who are the Youth Ambassadors? So these are highly motivated professionals working in cancer-related field, and they are from over 30 countries across Europe, and they do everything to promote European Code Against Cancer, to raise awareness about the cancer prevention, the ways you can prevent it, and to research and advocate for cancer prevention. They meet this European, the youth ambassadors of the European Cancer Leagues meet each year to discuss strategies on cancer prevention, and also there are working groups, research working groups, events working groups, advocacy. Each European Youth Cancer League's ambassador works in one of the research groups or in two of them, and based on the group that they are involved in, they're taking actions to either organize events that will lead to the raising awareness of cancer prevention, or doing research to understand, to investigate this issue, to understand how people how much people are familiar with ECAC, and so on. So here you can see the countries where we have ambassadors from, and overall there are 60 ambassadors from over 34 countries across Europe. So as I said before, youth ambassadors take actions to raise awareness about the ECAC. There are individual actions such as participating in webinars, such as being a speaker in webinars, such as educating the local public, and joint actions together with other organizations such as this program, which is in the framework of European Week Against Cancer, and also in the World Cancer Day. We usually organize some events. We usually try to are more active during these days to try to come up with new projects, trying to come up with something interactive, something interesting, so people will benefit most during this important days. So the next slide. And today I would also like to share my own experience as a youth ambassador. As said before, I and my colleague Vaginag become youth ambassadors from Armenia. We were the first youth ambassadors from our country, and actually no one in Armenia knew about ECAC before. So we had a lot of things to do, and from day one we started to actively promote ECAC in our country via social media and on-site projects. So Vaginak was mostly responsible for social media platform and for translation of the manuals into Armenian, translation of the all materials that we had, the posters, the leaflets. He did it very, very good, and till now he's the administrator of the Facebook page, and is regularly posting a lot of informative and important facts about cancer prevention. I and Varnak has also delivered the posters and leaflets to various healthcare facilities in Armenia, to educational facilities. So the posters of ECAC are everywhere in Armenia, and we also participated in summer schools. We also gave seminars and webinars in Yerevan State University. So we're pretty active, and by that time, when I was also just started to work on ECAC, I was also simultaneously doing an HPV study in Armenia, which was about evaluating the accessibility and knowledge on HPV vaccine acceptance and HPV vaccine acceptance in Armenia. So till now, based on the results of the study, I'm trying to do some interventions and second stages of the study. And also by getting involved in the research group of youth ambassadors, I'm participating in research projects. We have published abstract on the secondary cancer prevention among the youth research status and policy recommendations for the EU. And now we're working also on the on a survey, an international survey regarding the understanding of the ECAC and the knowledge on ECAC. We also have printed a lot of materials, as I said before, and we printed some notebooks, some pens to give to the participants during our webinars. And also I've printed a calendar that had 12 recommendations, one recommendation each month, and we give it to cancer patients at the Hematology Center of Armenia. So every month they can see the recommendations, and this may also lead to the secondary cancer prevention, which was actually, I think, a very nice idea. So it's like every day when people are looking to the calendar, they also see the recommendation, and this always like this visual memory will somehow affect their behavior. So next slide. Yeah, okay. I think that
that's it. Thank you so much, Eva. So now we move on to Dr. Thorat, and while he shares his PowerPoint, I'm taking a second to introduce him. Dr. Thorat is a specialist breast and oncologist, a surgeon by training, and he works at the Center for Cancer Prevention at the Wolfson Institute of Preventive Medicine, where he's researching breast cancer biomarkers with a special focus on DCIS, a pre-invasive stage of breast cancer. His research will eventually allow us to spare a large majority of DCIS patients from adjuvant treatments like radiotherapy, and thereby avoid the side effects of these treatments. So thank you very much. Oh, you're still muted.
Usual problem, sorry.
Yes.
Sorry about that.
Perfect.
Good afternoon, everybody. Thank you, Francesca, for that kind introduction, and may I thank organizers for giving me, inviting me to give this talk, which is close to my heart. I'm going to today talk about hormone replacement therapy and cancer risk. And one of the reasons why this talk is somewhat close to my heart is uh, I see world these days world is quite a lot polarized, and sadly HRT is one area in medical science where the opinion is also somewhat polarized, whereas in reality there is no need to be so polarized. So I hope that through this talk I will be able to discuss the risks and give everybody a somewhat of a pragmatic view on HRT and cancer risk. So as Eva mentioned before, in European Code Against Cancer, recommendation number 10 is hormone replacement therapy increases risk of certain cancer, and therefore women should limit use of HRT. Uh, in my talk, I'm going to cover recent history of hormone replacement therapy. Then I will go on to discuss the evidence of hormone replacement therapy and breast cancer risk. And I will touch upon how to mitigate that risk. And after that, I will discuss the evidence of HRT and risk of other cancers, covering colorectal cancer, ovarian cancer, and endometrial cancer.
Mangesh, I'm very sorry to interrupt, but hi Mangesh, this is David from ECL. We don't see, we just see the first slide. So
Oh, it's not.
It didn't progress. I think you're up to the overview slide, so you can just try.
Yeah, I'm on slide 3. It hasn't moved.
Yeah.
Is it? Can you see this way? Is it showing second slide now?
Yeah, good if you can do the full screen view, if possible.
Yeah, that's what I did. And then I went to the slideshow mode and it didn't work.
Let's see.
Why don't I? Let's do it this way. Is it better? This will show up.
Yeah, this is okay for us if you're okay.
Yeah, let me see if I can. Okay, I think let's make do with this. So yeah, I was on the overview slide, and so lastly, I will cover the hormone replacement therapy and risk of other cancers, covering colorectal cancer, ovarian cancer, and endometrial cancer. So in summer of 2002, this is about exactly 20, almost 20 years ago, a big fuss kicked up when Women's Health Initiative, a large randomized trial in USA, was stopped as it reported, the interim analysis reported excess strokes and breast cancers, and the trial was abruptly stopped, and the results were published. What you can see happened immediately afterwards is that the use of HRT had been progressively increasing before summer of 2002, and then it suddenly dropped following the publication of these trials results. There was also a suggestion that the annual incidence of breast cancer in USA dropped in the following 2 years, and this was attributed to sudden decline in HRT use. Although, as I pointed out at that point in time, that the decline was caused by actually reduction in screening uptake, and it was only sustained by reduction in HRT, and that is the view that has subsequently have come to be accepted as a more reasonable explanation. So coming to the evidence of hormone replacement therapy and breast cancer risk, I will be discussing evidence from randomized trial. Mainly it comes from Women's Health Initiative trial, but I will also discuss evidence from observational studies. These are retrospective observational studies or pooled analysis of prospective observational studies and real world database based studies as well. So what does these studies show? I've chosen these 4 studies as they present the best quality evidence and present a clinical trial setting picture as well as real life setting picture and the situation in between. So as you can see from the table here, barring the exception of Women's Health Initiative trial as far as estrogen only hormone replacement therapy is concerned, HRT is associated with much greater risk of breast cancer. Estrogen only HRT is associated with about 20 to 30% increase in risk of breast cancer, and combined HRT, which is estrogen and progesterone, together is associated with near doubling or doubling of risk of breast cancer. The reduction seen in the Women's Health Initiative trial has several possible explanations and does not necessarily contradict the results from other studies, and should be looked at as an exception rather than a rule. On this somewhat busy slide, this is a real world scenario. You can see these are different agents, formulations of HRT and breast cancer risk. So if you just look at the top of the top three panels, these are three broad HRT formulation groups. Panel A is estrogen only, panel B is combined HRT, and panel C is tibolone, which is a synthetic HRT, which is akin to combined HRT. These dark purple or violet lines are the risk of current or recent use of HRT, whereas these dashed yellow lines represent risk associated with past use of HRT. As you can see from left to right, the longer the duration of use, the greater the increase in risk. But it's very obvious from these plots as well that the risk associated with estrogen only HRT is much smaller as compared to risk associated with combined HRT or even tibolone. Focus now on the yellow plots. It's quite clear that it's only the combined HRT that seems to be really associated with increased risk if HRT has been used in past and it's not currently used. Now, the definition of past use here is 5 or more than 5 years ago. Coming to the second and third row, these are individual formulations. D and E are estrogen only HRT formulations, and there is not much difference between the two. But if you look at the other four panels, which are the combined HRT panels, you can see that the estrogen and medroxyprogesterone combination is associated with the greatest increase in risk, breast cancer risk, panel F, as compared to the panel I, which is estradiol and dihydrogesterone combination, which is associated with much smaller increase in risk. The bottom line is that not all HRT formulations are same, and there are quite substantial differences amongst them. It's something that needs to be taken into account when considering use of HRT. This is another busy slide. Draw your attention to only specific areas of this. You will get these slides so you can carefully look at this, and the references to the original papers are also included, so you can look up the original paper as well. But these three plots are women of different age groups: 50 to 60, 60 to 70, and 70 to 80. And the numbers here represent the excess breast cancers caused if 10,000 women took HRT, and these are number of excess breast cancer caused in 1 year. And the numbers range from 3 to 36, so almost a 10-fold difference. And so this increase in 3 is a current or recent short duration HRT used for estrogen only HRT, whereas the 36 excess cancers are caused if a combined HRT is currently used and the duration of use has been greater than 5 years. So this is in women who are aged 70 to 80, whereas in younger women, the risk is much excess breast cancers caused is much smaller. And this brings to the other point that the excess cancers caused also depends on the baseline risk in that individual woman or a group of women. And that's something that needs to be taken into again account when considering use of HRT. So when we see so many excess cancers caused, and it rather presents a a scary picture. So should we stop using HRT completely? And the the answer is not as black and white as one would like to say. It's not a clear yes, it's not a clear no, but it's rather 50 shades of gray, or as 49 shades of gray as shown in this table here. So increasing duration of HRT increases the risk of breast cancer. Baseline risk of that individual also increases risk of excess breast cancers. Drugs and drug combination have varying patterns of risk, and same goes with modes of drug delivery. For example, vaginal estrogens don't seem to be associated with excess breast cancer risk. So depending on individual woman's characteristic and the formulation used and the mode of delivery used and duration of use, a woman could sit in any of these any of these gray boxes, and accordingly then, once she has the information, make a call as to whether to take HRT or not. And so the main point I want to drive here is that there is no right or wrong answer here. Each individual is different, and each individual needs a personalized recommendation. And to arrive at that personalized recommendation, it's important to understand the risk, and it has to be a shared and informed decision between a healthcare provider and the individual. So the factors that drive baseline risk are age, which itself is a risk factor. There is some suggestion that HRT effect may be greater at higher age, but the evidence is really mixed on that. Obesity, as we know, is associated with greater breast cancer risk, but interestingly, it's also associated with lower hormone replacement therapy associated risk. Family history is associated with greater breast cancer risk, and when a person has a greater baseline risk, obviously the absolute increase in the risk associated with HRT will be greater for that individual as compared to rest of the population. Mammographic breast density is another indicator of breast cancer risk. The denser the breast, greater the risk. And add to that, hormone replacement therapy increases the breast density further and thereby reduces sensitivity of mammography for early detection. And that's something that needs to be taken into account before starting and considering HRT.
Sorry to interrupt. We have to start wrapping up if that's okay, so we can make sure
yes.
that we keep staying to time. Thank you.
So it's also important to take into account indications. So there are certain symptoms where HRT is the only solution, but there are other signs and symptoms such as osteopenia or osteoporosis where alternatives exist, and therefore they need to be considered over HRT. As I said, drug delivery and duration all make a difference. Longer the duration, greater the risk. Coming to the other cancers, HRT seems to be associated with reduced risk of colorectal cancer, but this is based on a much smaller body of evidence. And in any case, the incidence of colorectal cancer is not as high as breast cancer, and therefore, even if this effect truly exists, the number of colorectal cancers prevented will be much smaller than the number of breast cancers caused. Coming to ovarian cancer, it is also associated with increased risk of serous and endometrioid ovarian cancer and overall ovarian cancer risk. Early evidence suggested this to be associated with estrogen-only formulations, but now it's clear that it's associated with any type of HRT. And A systematic review also shows that HRT is associated with increased risk of endometrial cancer, even with short duration of use. So in summary, HRT use is associated with increased risk of breast, ovarian, and endometrial cancers. The risk of colorectal cancer is possibly reduced. Breast cancer being the most common cancer in women, and HRT use being associated with the greatest relative increase in risk. This remains the most important public health concern. HRT was actually, it was thought that HRT would prevent cardiovascular events. Sadly, that has not materialized. On the contrary, risk of strokes is actually increased. All HRT formulations, with possible exception of vaginal estrogens, are associated with increased breast cancer risk, but each formulation has a different risk estimate than other. Longer the duration of use, greater the increase in risk. Increase in risk is higher in non-obese women as compared to obese women, and HRT reduces sensitivity of mammography. So for each woman considering HRT, she needs to discuss all potential benefit and harm implications with her doctor for a personalized recommendation. And if elected, use of HRT should be for as short duration as possible. Thank you.
Thank you so much, Dr. Thorat, for this informative overview of the link between hormone replacement therapy and cancer. And it's very interesting for me to hear the risk associated and the factors involved to making an informative decision. So the floor is now open for a couple of questions from the audience. Please, if you haven't already done that, add them to the Q&A section of the webinar so that we can go through them and give them to Dr. Thorat.
Okay, so thank you very much, Mangesh. It was a great presentation. We really appreciate the time to deliver this presentation for us today. I think that there are two things that emerged initially when we've been discussing this with colleagues and from people also I can see in attendance here today at the webinar. And the first one is as you outlined in the summary presentation, that with regards to the link between hormone replacement therapy usage and obesity, you see that it's higher in non-obese women. So if we can just unpack this a little bit more, because as it says in the slides, as we know, we see body fatness, obesity as an increasing risk factor for breast cancer. So what's known about this interplay between hormone replacement therapy use and body weight?
So so the jury is still out on what the actual mechanism behind this is, but it's an interplay. So the more body fat one has, more aromatase activity they have, and more endogenous estrogens are synthesized, and that is thought to be one of the major drivers behind their originally increased risk. But this risk is only seen in postmenopausal women who are the candidate for HRT use. What essentially happens is, if we look at estrogen only HRT, then as the body mass index increases, the HRT risk is stable. HRT associated risk reduces, whereas the baseline risk is increases. So at a higher body mass index such as 40, their baseline risk and HRT induced risk, those two curves meet. But if we look at combined HRT risk, then again the absolute increase in risk is smaller with each increment in body mass index, but the overall risk is still higher than without HRT. And so it shouldn't be taken as if somebody is very obese or overweight, that HRT will not have impact on them. At certain point, the curves meet for very high body mass index, but that's only for estrogen only HRT. And it's the interplay of endogenous estrogens with the HRT formulation that causes this. And one of the reasons why we see these slight differences between the Women's Health Initiative trial and the observational studies, from majority of those coming from Europe, possibly could be due to higher obesity and body mass index in US women, almost half of the women in that trial were actually obese.
That's very clear. Thank you very much for that excellent answer. And I suppose the link to that then is, we only have time for this final question, but as a clinician yourself, what's your experience of delivering the shared decision-making process with women in regards to their decision whether or not to proceed with hormone replacement therapy? And do things like the body weight come into this discussion more and more? And how just from a personal point of view, how have you found this?
So what I generally talk to them is about their baseline risk first, and the magnitude of increase that will be expected with HRT in absolute numbers. Now, if somebody's baseline risk is 20% because of their breast density and overweight, we have models to estimate baseline risk. The Styrer-Cuzick model or IBIS-1 model that we commonly use, and then we can impute the absolute risk associated with HRT if they use a specific formulation, and then it's a discussion between, if the absolute risk is 3%, absolute increase in risk is 3%, that means it's a 1 in 33 chance. And that's something that women understand better, whether she would want to take that 1 in 33 chance as compared to what symptoms she is experiencing and the alleviation. And one of the key things to remember is that this is a medication, it's not a surgery, and it's fully reversible. So if you are not gaining the benefits you were hoping to gain, then you could stop it at that point as well. So sometimes it helps to give it a try if that's the decision that you came to, and then see how it whether it's really alleviating the symptoms. If it's not, then, and if it's just going to cause you excess harm, then you might as well stop it. So yeah, but I normally basically start with baseline risk, which would be higher in obese women, but then we would also drive down the effect size to estimate the absolute increase in the risk.
Excellent. Thank you very much. I'll hand back now to Francesca to judge this next speaker. Thank you.
Yes, thank you so much for your participation, Dr. Thorat. So now allow me to introduce our second keynote speaker, Dr. Romieu, while she shares her screen. Dr. Romieu is a medical doctor by training and a senior visiting scientist at the International Agency for Research on Cancer, where she was the former head of the section on nutrition and metabolism for 6 years. She is also an adjunct professor at the Rollins School of Public Health at Emory University and honorary professor of epidemiology at the National Institute of Public Health in Mexico. So Dr. Romieu, the floor is yours. You can share your screen with your presentation. Or you're still muted.
Do you hear me?
Yes.
Okay, perfect. I just want to share the slides. Okay, thank you very much for your introduction. I'm very pleased to be with you this afternoon, and I will be presenting data on the impact of breastfeeding on breast cancer. And as you know, it's part of the 10th recommendation of the European Code Against Cancer, and it's read as, for women, breastfeeding reduces the mother's cancer risk if you can breastfeed your baby. So first of all, I wanted to remind you the importance of breast cancer in the world. Breast cancer is the first cancer in women in the world and in Europe as well. And in 2020, close to 576,000 cancer have been diagnosed in the European countries. WHO recommend exclusive breastfeeding for 6 months after birth to reduce mother's cancer risk. And this recommendation, unfortunately, is not so well understood, I think. And although breastfeeding rate at the beginning is important in a European country, with time it decreased a lot. And by 6 months, only 25% of women are breastfeeding their baby. So breast cancer, as I say, is a very important cancer, and it's 25% of all cancer in women, both in Europe and in the world, and follows by colon cancer and lung cancer. And if we looked at the distribution by European region, we can see that in blue, we have the rate, which is the number of new cases by 100,000 women. And in red, the mortality, which is the number of deaths by 100,000 women. The highest rate are observed in Western Europe, as well as Northern Europe, and lower rate are in the Southern Europe and Central Europe. In relation with mortality, there have been a very important decrease in the last 40 or 30 years because of earlier diagnosis and better treatment. So what are the data that show that breastfeeding is related to a decreased risk of breast cancer? Here I'm showing data from the collaborative group on hormone factor in breast cancer, which is a large study of more than 50,000 women in 130 countries. And this study has shown that there was almost linear relationship with a decrease in breast cancer in relation to a cumulative effect of breastfeeding. And the estimation based on this study is a decrease of 4.3%. Reduction in breast cancer risk for every 12 months of breastfeeding. And it's important to note that this is on top of the productive effect of having children. And in this study, the effect was observed in pre- and postmenopausal women. So more recently, there have been some other study looking at the effect of breastfeeding on breast cancer. And here I'm showing a meta-analysis, which means the combination of the results of different studies, which have been following women over time to look at the impact of breastfeeding on the incidence of cancer. And this analysis have been done by the World Cancer Research Fund, which is an organization who really focus on diet, nutrition, physical activity, and cancer. And we get similar results on the combination of 13 studies. The decreased risk is 2% for each 5 months increase in breastfeeding. Here you can see the different study with their estimation and the summary estimate here. So what does that mean? That means that breastfeeding, which is a modifiable factor, and I think that's very important because it's something that you can do to increase protection, is important to understand that it's the number of cumulative months of breastfeeding which we have had on for a protective effect. Here we have a woman who had breastfed 2 children for 3 months each. So the total cumulative breastfeeding is 6 months, and she would have a decrease of close to 2.4% because what our estimation is based on 2% for 5 months breastfeeding. Another woman here will have 2 children, and she will have fed the first one for 7 months and the second one for 5 months. So having a cumulative breastfeeding of 12 months, and her decreased risk will be 4.3%. So I think it's important to promote breastfeeding because, as I mentioned before, the rate of breastfeeding at 6 months is quite low in Europe, and there is some very clear factor that can explain the effect of breastfeeding on breast cancer. Here, I want to focus on the mechanism we know about this effect. First, we know that the breastfeeding, there is a maturation of the breast cells, which reduce the susceptibility to the breast tissue, to the carcinogenic effect of different factors, in particular hormones. We also know that breastfeeding has a hormonal effect on inhibiting ovulation, which means that there will be a reduced exposure to hormone level also linked to the breastfeeding. Breastfeeding is also related to excretion of carcinogens through human milk. In particular, it helps to exfoliate breast tissue, which might have some DNA damage and therefore decrease the risk of later mutation. And there is an important impact on the serum insulin level, in particular acting on the insulin growth factor, which is a promoter of different cancer. And by lowering this level, there is also a protective effect against breast cancer. Something also that has been observed is that exclusive breastfeeding, that means during 6 months, which is what's recommended by WHO, the child just received breast milk, has even a stronger effect, hormonal effect in the mother. There are also some data that have shown that breastfeeding could have an impact on ovarian cancer, and the effect is estimated of about 4% for 6 months cumulative breastfeeding. Here we have less study on this cancer because this cancer is much less frequent than breast cancer. To have an idea of magnitude, the overall incidence is close for breast cancer, close to 100 women for 100,000, and for ovarian cancer will be 10 women for 100,000. So there is a difference in magnitude, and we have less data on this effect. And the mechanism will also be by a delay in return to menstruation, which means that you have less exposure to hormones and then less possibility of having mutation and cancer. So I was mentioning the poor level of breastfeeding, exclusive breastfeeding at 6 months in European country. Here you can see actually the result of a survey from 2019, which clearly show the low level at 6 months, which is the blue line. The highest level are observed in the Netherlands, which are close to 39%, and the lowest are in Switzerland, which is close to 10%. And then you see other countries which are also pretty low. So I think that shows that there is a lot to do on promoting breastfeeding among women in Europe. Another important point, and I think that's also something that need to be promoted, is that breastfeeding has also other benefits for the mother. It's clear that it helps the mother return to her weight prior to pregnancy, and also reduce long-term weight gain. And there is data showing that middle-aged women who had breastfed had a lower BMI than their counterpart. And another important, and I think a major factor is the benefit for the child. So we know that for the first 6 months of life, breast milk is the best food for the child. It helps protection against infectious disease, against diarrhea and respiratory infection. It's also, many studies have shown an impact on cognitive development, in particular because of the content of polyunsaturated fatty acids in a mother's milk. And it also shows an impact later on chronic conditions such as asthma, obesity, and diabetes within childhood and later in life. So there is really a cumulative amount of data showing the importance of breastfeeding as well for the child. I will emphasize the impact of breastfeeding on obesity. We are in a situation where obesity is really the most prevalent chronic disease. And what's really worrying is the increase of obesity in the children, because we know the consequences on the health later on. And here you can see that it's based on the Childhood Obesity Surveillance Initiative from the WHO, showing that children who have never been breastfed in those different countries, the mean prevalence is close to 17%, while if you compare to children who receive breastfeeding for 6 months or more, the prevalence is 9%. So I think that's, the numbers speak by themselves on the importance of breastfeeding. So I just want to show some pamphlet of the WHO Europe to remind the benefit of breastfeeding, both for the child and for the mother. And right now, I think the issue is how do we promote breastfeeding? Because as I mentioned, it's something that almost most women, I know some women will be very difficult to breastfeed for some physiological reason. But I think what's needed to be done is to help and promote the condition to support women to breastfeed. And the European Union has worked on that. And in 2004, there was a blueprint for action for breastfeeding, which was developed. And it's a model plan to, that outlined the action of a national plan to help and support breastfeeding. And I think with the national initiative, that's really is an important package to promote breastfeeding. Another important point is that the EU law forbids discrimination against breastfeeding, and especially at work. So two elements which I think are fundamental for the promotion of breastfeeding is first the International Code of Marketing of Milk Substitute that was developed by WHO, UNICEF, and other international organizations in 1981. And it's prohibit any form of promotion of breast milk substitute, including advertising given to health worker or distribution of free sample in clinics. Also, there is a need for product substitute not to include any claim about health or nutritional benefit. And there is also, should include a message showing regarding the superiority of the breast milk over the substitute. Another important steps is the International Labour Organization Protection for the Mother Convention, and that's been developed in 2000. And this convention that has been signed by many countries, it's promoted at least 14 weeks of paid maternity leaves and recommend to provide at least 18. And there are also a lot of recommendation about workplace to support breastfeeding and conditioned breastfeeding. And several surveys have been done and really show that the maternity leave policies have been shown to have a strong positive impact on the initiation, the exclusivity, and the duration of breastfeeding. So I think there is really data out there to support the law for helping mother to breastfeed. WHO Europe is also playing an important role to promote those conventions and policy, and especially in terms of enacting paid family leave, both for mother and father. And there have been developed the 10 steps to successful breastfeeding, which is a code who help probably more direct to health worker who can help women to start breastfeeding and do breastfeeding in good condition. And then also support access to skilled breastfeeding counseling, because when you're a mother and you don't really know how, or it's difficult to start breastfeeding, you really need some help. And I think that's extremely important. And then also to monitor the system that track the progress of policy in the different countries.
Sorry to interrupt, we have to wrap up here.
Yes,
yeah.
I'm finishing. Yeah.
Okay, perfect. Thank you.
Yes, I just want to speak about one comment of a general practitioner from special clinics in Sweden, who say that to promote breastfeeding and raising awareness about the health benefit of breastfeeding among the population should be a health priority. And education, both health workers and parents, would encourage overall positive attitude towards breastfeeding and have far-reaching benefits for family and community. You can find the website. So to conclude, I think breastfeeding is a modifiable factor, and that's extremely important. Any breastfeeding is good, more is better. And I think the three most important points there is that breastfeeding is protective against breast cancer. Breastfeeding brings several other benefits to the mother and the child, and that breastfeeding should be very actively promoted given the rate observed in the European Union. Thank you for your attention.
Thank you so much, Dr. Romieu, and thank you for this interesting overview of the link between breastfeeding and cancer prevention. So now there's time for a few questions for the audience, and my colleague will take over.
Thank you very much. Thank you, Isabelle, for another great presentation. We just have time for a couple of quick questions. So the first one is about, you can hear me okay? Yeah.
Yes. Mm-hmm.
Yeah, great, just to check. The first one is about the measurement of breastfeeding rates. So this typically is something that's self-reported through survey, health interview surveys, or through reports from observation by maternity nurses and so on.
Yes, yes, of course. I mean, the data I showed from 2019, it's a survey. So basically, it's based on questionnaire, which is asking both at the mother, also in the clinics, because there is no way they could have the exact breastfeeding. And one issue which is difficult is really to get the data on exclusive breastfeeding. And what I wanted to mention a point there, that the study I showed in terms of the effect of breastfeeding are just based on the number of months, but not only on exclusive breastfeeding. And I think that actually the protective effect will be even stronger when we speak about the first 6 months of exclusive breastfeeding.
Excellent, very clear. And regarding the rates over time in terms of what's reported for breastfeeding, either exclusive or mixed, there's been some highlighting of this issue, which is good in public health terms over recent years. Do we see any positive increase in the trends in terms of breastfeeding rates within Europe over the last decade or so, or is it not entirely clear?
I think it's really depend on the country, and I think actually the rate is increasing slightly, but I won't be able to tell you exactly where. I think, you know what, for breastfeeding, first we really need to tell the woman that it's extremely important for them and for the baby, because I think, you know, the benefit on the baby, there is no question about it, because there've been it's maybe easier to follow on the baby than cancer, which is a long-term disease, you know. I mean, before you get the exposure and you get the cancer, you have a lot of time. But for the baby to look at neurobehavioral development or to look at infection in the first year, it's very close to birth. So here we have excellent data to show that, you know, breastfeeding is really the best. In terms of the cancer in the woman, in the mother, I think most of the data I know have really shown an effect, and I've been working in Mexico and Latin America, and where breastfeeding is much more prevalent, and we really see a strong protective effect on breast cancer there also.
Great. I see that Mangesh would like to ask a question. Please do take the floor.
I just wanted to add a comment, especially about the exclusive breastfeeding, and I just wanted to reiterate that it is such an important factor, and it's the bottom line is it often stems from concern that whether women are producing enough milk or not, and they are practically, it's a demand and supply situation which nature has mastered over, you know, thousands of years of evolution. So they are always producing enough, so that alleviating that concern is important. And second factor that comes into humans, we are lazy. So if you give a bottle, the baby prefers that so much more because it's much easier to consume, and that's where if you introduce bottle, the rate of breastfeeding then starts dropping dramatically. So if one needs to, in order to ensure longer duration of breastfeeding, I think a strong message of exclusive breastfeeding is important.
Yeah, thank you very much for your comment. I totally agree. Although right now they're doing some bottles who are force the baby to pump more, like especially for women who have to pump their breast milk, and then, you know, the breast milk is then given to the baby in the bottle, because when women works, it's not although there is some law, and I think there is a big step which has been going on towards allowing women to breastfeed at work and to have some support. It's also, I mean, many women have to pump their milk and give them after, or somebody else give them in a bottle. That happened to me, so I know.
Excellent. So I hand back over now to Francesca to wrap up.
Yeah, thank you very much. It's now time for an interactive quiz, and the quiz will appear on your screens in just a second. Jeva will read the questions out loud and give you some time to reply to each of the questions.
So, should we begin?
Yes, please.
Okay, the first question is, which of the following statements is wrong? Please select a single answer. Breastfeeding helps to remove carcinogenic cells from breast tissue. Fewer ovulations are correlated with reduced risk of breast cancer. Breastfeeding increases the serum insulin level, or breastfeeding increases susceptibility of breast tissue to carcinogens.
Yeah, we can go to the next question, I think,
Okay.
while they're answering.
Should I say the right answer?
We will email everyone with the right answer afterwards.
Okay. For which cancers is breastfeeding a preventive factor? Please select one of the answers. So none, ovarian cancer, breast cancer, or both?
Yeah, you can keep going with the questions.
Which of the following are known benefits of breastfeeding? Please select one of the answers. Breastfeeding helps to return to pregnancy weight. Breastfeeding reduces newborn susceptibility to infectious diseases. Breastfeeding contributes to the baby's cognitive development, and all of the above. The fourth question is, which of the following statements is wrong? Please select one of the answers. Vaginal estrogens increase the risk of cancer. Hormone replacement therapy increases the risk of stroke. Hormone replacement therapy may reduce the risk of colorectal cancer. All of the above. And the fifth and last question is, hormone replacement therapy increases the risk of, please select one of the answers. Cervical cancer, increases the risk of ovarian cancer, colorectal cancer, all of the above.
Okay, thank you. We'll give you a minute to answer all the questions, and then my colleague David will give you some final remarks before closing up.
Thank you, everyone. It was really excellent set of presentations. So thank you very much to Mangesh and Isabelle for the great presentations and the answers to our questions. They really appreciated it. We appreciated hearing about this important message from the code today. And thanks also to Jeva for joining us, the co-host who organized the webinar, and for putting together the quiz, which is a way we can do a little assessment of how participants have been following the question, the information today from the different presentations. So just to briefly recap, we've heard about hormone replacement therapy and breastfeeding, which is the message 9 from the current edition of the European Code. And I really liked how Mangesh phrased it, that this is not a black and white issue, and actually there's almost 50 shades of gray involved. That depends upon the individual women, but also, of course, depends that we have to understand that as all women are different, so too, not all HRT, not all of these therapies are the same. So this really requires careful individual level decision-making, understanding the baseline risk a woman has to begin with, and then what type of therapies are on offer, the duration and so on, and they can then make a decision that really suits them. But of course, as Mangesh said, this is not permanent. There's possibility to correct and roll back a little bit there. So the message I take home here is really, this is something that a woman has to consider carefully, talk with her provider, and make the decision she wishes to make in line with her preferences. And then accompanying this is the other part of the message, which is for women from the code. And that's the clear, very clear message about breastfeeding as a positive protective factor, especially for breast cancer. And it was very great to see Isabelle's slides, which really outlines the mechanisms of play that show us and demonstrate how this takes place, this protective effect, because often when we have these webinars, we always come to one point where we need to know more about the mechanisms, but I think here we know. So this is really, I think, a good point, and we need to really drive home the policy recommendations here in order to allow women who can breastfeed and who are desiring to do so, ideally exclusively for that time period, at least 6 months, but to allow them and support them to be able to do that in a way that is most convenient for them. So this requires greater support from society in terms of the workplace and elsewhere to ensure and enable women who are able to breastfeed that they can actually actively do that, because the clear message, the main take-home message, of course, is that there's the protective effect for reduction of risk for breast cancer for a woman, but also for the infant, for the child too. So this really gives a great societal benefit as a result. So thank you very much. Those are my thoughts, my reflections from these two brilliant presentations. And I remind you now in the final minutes to complete our feedback survey, which you will get shortly afterwards, along with the answers from the quiz. And then last but not least, very important, that today is day 1 of the European Week Against Cancer. We're focusing today on primary prevention and health promotion. So do keep an eye out on ECL's social media channels and outputs regarding more information on the European Week Against Cancer. It begins today, 25th of May, and ends next Tuesday on World No Tobacco Day, the 31st of May. There are more information in the chat, and it will be sent to you afterwards in terms of other events and things that are taking place within the frame of the European Week Against Cancer. And then related to the topic that we've been discussing here today, and in August, from the 1st to 7th, there's World Breastfeeding Week. So do take a look at some information there and see how we can build on this important message, thinking about the application, the policy, populational supportive measures that we can take to allow women to be able to take up this important factor for themselves and for a child. So that's in August of this year, so keep an eye out and check for that. And of course, in the follow-up, feel free to get in touch with the ECL Secretariat with any questions or ideas for further suggestions on how we can build on this issue. So thanks again for our speakers. Thank you, Francesca, for moderating, and of course to Yeva, our Youth Ambassador, for joining us today. You'll receive everything by email, and we hope that you will join us in celebrating the European Week Against Cancer this week, and keep an eye out for the next in the series of webinars, which will be in the autumn of this year. And these are the webinars to talk about the messages of the European Code Against Cancer. So keep your eyes peeled for information for the next webinar. Thanks, everyone.